Hello, welcome to Faith Community Research Network Medical Mythbuster Show on cancer. We're so happy that you joined us. The Faith Community Research Network is a collaboration between Wayne State University, Carmano's Cancer Institute, and the Faith-Based Genetic Research Institute. One of our primary reasons or aims for doing these type of shows is to myth bust some of the things that's happening in the community and to educate and disseminate the proper information to the faith-based community. Many of us who have grown up in church or have a faith background know that it's in the churches that we get our information and have our community and our family, and we want to make sure that you all have the proper information. So today we have a dynamic panel of experts that will bring this educational information on cancer mythbusters to you. We have today with me Vancille Brown Miller. She will introduce herself, and then Dr. Haley Thompson. After that, we have Dr. Assad and Dr. Powell. Vancille?
Hi, I'm Vancille Brown Miller. I'm with the Office of Cancer Health Equity and Community Engagement. I'm the Manager of Community Outreach. I oversee Cancer Action Councils. Those are groups of individuals who come together monthly to give their concerns and to learn more about research in cancer. Glad to be here.
Thank you, Vancille. And I'm Rochelle Chapman. I am the co-director of Faith Community Research Network and also the Community Engagement Coordinator for the Center of Urban Responses to Environmental Stressors and a senior pastor for 12 years now here in Detroit. Next, we'll have Dr. Haley Thompson that will introduce herself and tell us a little bit more about her research and background.
Hello, everybody. Thank you for having me here today. I'm Haley Thompson. I'm a professor in the Department of Oncology here at Wayne State University School of Medicine. I'm also with Carmano's Cancer Institute. I serve as one of the Associate Center Directors for Community Outreach and Engagement. And I'm also one of the co-directors along with Pastor Chapman of the Faith Community Research Network. And my research, I'm a clinical psychologist by training, not an oncologist, not a physician, but a clinical psychologist. And I do what's called behavioral research. And I look at the reasons why people may or may not engage in healthcare. And so earlier in my career, my focus was very much on cancer screening, thinking about why people would get screened for cancer or would not be screened for cancer or avoid getting screened for cancer. And more of my work now is on cancer survivorship. What are people's experiences like after treatment? And so I'm one of the principal investigators for a large-scale study called ARISE, African American Resilience in Surviving Cancer, where we're looking at different factors that affect outcomes among Black survivors in Metro Detroit. Thank you.
Thank you, Dr. Thompson. Dr. Assad?
Thank you for inviting me here today. I'm very happy to be part of this wonderful panel. I'm Hadil Assad. I'm a medical oncologist and assistant professor of oncology at Wayne State University and Carmano's Cancer Center. I'm also part of the breast multidisciplinary team and the early therapeutics clinical trials program. What that means is I primarily treat breast cancer, and I also am involved in clinical trials studying new treatments and new drugs. My primary research interests are in communication and how to improve communication between patients and physicians. I'm also very invested in working on new therapies or new therapy combinations, such as immunotherapy and targeted therapies to ultimately improve patient outcomes, and how to overcome drug resistance in cancer treatments. Those are very big research topics in the cancer world, and my primary research involves areas involving these topics.
Thank you, Dr. Assad. We definitely look forward to hearing more about that. And also another one of our superstars here. We have Dr. Powell, and we're going to allow him to introduce himself, but he almost needs no introduction. World renowned. If you Google his name, you'll find all type of interviews in today's show and various other things that Dr. Powell has done. He's a young man getting great strides in cancer research and as a doctor, and you'll hear more about his research. And we're just so happy and excited to have Dr. Powell on our panel today. Thank you, Dr. Powell, for being here.
Thank you, Reverend Chapman, for the introduction. Yes, I'm a urologic oncologist. I've been at Wayne State University and Carmano's Cancer Institute for 35 years. And my area of interest is racial disparity. The barriers of why men don't come in was my initial research to be tested and to be treated. And what we went to 51 churches in Detroit over 2 years and found out that the main reasons why they don't is the mistrust of the white healthcare system based on historical issues that we all know about, and also the fear of the diagnosis. They thought that if you have cancer, you're going to die, and so they did not want to address that issue. Then I went from there to research in terms of lifestyle and diet, and finding that the high-fat diet causes cancers to progress. Also, obesity, particularly belly fat, was associated with aggressive cancers as well. From there, we identified the fact that African Americans have a faster growing prostate cancer than other ethnicities. And so we wanted to find out why. So we know that cancer is a genetic disease. Something has to happen to the gene before cancer can actually progress or actually happen. And so we looked at the genes that were different, or we thought were different. In fact, the only difference is the expression of the genes associated with aggressive cancer were greater among African Americans than European Americans. And so then we wanted to know exactly which of the genes are responsible for that. And that's where we are today. We've identified 5 genes that are driving multiple pathways to contribute to the growth of the cancer, to the spread of the cancer, to blood flow in the cancer. And so the next step would be to try to inhibit those genes. And so we are now developing a drug to block those genes. We do have a study now at Carmanis where we're looking at people, men particularly, who are at risk for prostate cancer, don't have it, but they have a family history of prostate cancer or breast cancer or ovarian cancer. So that's a current study that we're trying to recruit men for at this time. Clinical trials are very important, and that's one of the clinical trials that we have now. And as soon as we develop this drug, we hope to be able to partner with a pharmaceutical company, and we have clinical trials to see if we can prevent death from prostate cancer, and that's our goal.
Wow, that's amazing. As you can tell, we're going to have an incredible show, and we're not going to run out of things to talk about. And so we want to just kind of fast forward some of these myths and talk about these. And so you guys can go, Vansila, if you want to start with one of the myths, and we want to continue that way.
Well, the first myth that I'd like to address, and it's based on something that Dr. Paul just said, and that is that if a female in your family has cancer and you're the male, you don't have to worry about getting cancer because you're a male. Female, they're just separate situations.
So yes, so these genes I'm talking about in prostate cancer are also genes that drive breast cancer, ovarian cancer, lung cancer, and colon cancer. So if members of your families have these particular genes, you're also at risk for having those genes that drive prostate cancer. So that's the reason why. We know that there's a common denominator that drives these solid tumors. In fact, lymphoma is also driven by these particular genes. So that's why we want to do this study. So we know that if you've got family members with these, you're more likely to have it too. Now, this is not the hereditary genetics that we talk about within families. This is another, another kind of hereditary genetic disease genes that are causing these particular cancers to progress within families or without families.
And men can have breast cancer too.
Yes, yep. Exactly.
Especially if they have a hereditary BRCA mutation. Mm-hmm. So that's why we recommend for men to get tested if they have a hereditary BRCA mutation in a woman. For example, a sister who has breast cancer, that they also get tested because they're also at risk of breast cancer if they have that gene and other cancers.
And see, that's one of the study that I mentioned where men don't have it but have risk factors. This BRCA gene that she's referring to can occur in men as well. Mm-hmm. But we know that also if they don't have it, they can be at risk for it.
Okay.
I think one of the takeaways there is that, knowing and understanding your family history is really important. Family members need to talk to each other. Sometimes I know in families, this has certainly happened in mine, people keep secrets about what they have and their procedures and what they've been treated for. And family history is really key when we're talking about genes and genetics and cancer. And we have to be talking about it across gender, and we need to be talking about it across generations.
Thank you, Dr. Thompson. Dr. Assad, can you address, we're going to rapid fire these myths. Can you address everyone who has the same kind of cancer gets the same kind of treatment?
Right, and that is actually a myth. That is not true. Even in breast cancer, women who are diagnosed with stage 1 breast cancer do not get the same treatment. Some women will get chemotherapy, others won't, because it depends on how aggressive the breast cancer is, what the receptors are, what the risk of distant recurrence or metastasis is. So patients do get different treatments, even when they're diagnosed with the same stage and same type of cancer, and it depends on these genetics or changes in that specific cancer. And we're heading towards precision medicine. What that means is that the traditional medicine, which is surgery, radiation, and chemotherapy, is not a targeted treatment. Now we're actually looking at the cancer genes and those mutations or changes in the cancer genes, and we're targeting that specific mutation. So these treatments are specific for that cancer and for that patient.
Wow. So, you just mentioned something about everyone getting a different treatment, but if you move from one hospital to the other, is everyone getting the same treatment? And there's some,
Right. Most of the time, the standard of care treatment is similar. If you get a second opinion, there are, some oncologists do treat cancers differently, so you can offer different options for patients. For example, if someone has breast cancer, you can have a lumpectomy, which is removing just a lump, or a mastectomy, which is removing the whole breast. So you can offer these different options for patients. And each one has a specific benefit. We know that lumpectomy and radiation, for example, is equal to mastectomy in terms of overall survival and recurrence. So we rather save the breast when we can. There's no reason to remove the breast. But, in certain situations, a woman might choose to remove the whole breast. So they may be offered different options.
I want to add to that because we also have cancers where we don't treat them, where we watch them. We call it active surveillance. In prostate cancer, we have that. People who may have a slow-growing cancer, and sometimes we can measure that by looking at the PSA and the actual cancer that we find on biopsies. Also in kidney cancer, now we're looking at active surveillance there. If they're very small lesions, we may follow them. In particular, the age of the patient. If the patient is an older patient with a small gland or small and slow-growing prostate cancer, or in a kidney cancer that is small and slow-growing, we may not choose to treat them because the treatment may be worse than actually the cancer itself. They may outlive the cancer, in fact.
Breast cancer patients that we just treat with hormonal therapy, for example, rather than surgery and radiation or the traditional pathway, for certain reasons. Sometimes it's age, sometimes patient, comorbidities.
Yeah.
So it's very different from patient to patient.
Here's a myth that I hear an awful lot, and that is once you have surgery on your cancer, that it just spreads all over the body.
Yeah. So there's no really there's no evidence that air or that having the surgery causes that to happen. There are multiple factors. Blood vessels go through these tumors, and the tumors can invade those blood vessels and spread to other places before we even remove it. So we may remove it and think we got all of it, and the patient will have a recurrence. And that's because the cancer was already spread before we got there. It had nothing to do with the surgery. The other thing is that some of the tumors are so large that they may go to the edge of where we think is the end of the cancer, and we can't really see grossly with our eyes that there may be what we call microscopic cells that are left there. And so in prostate cancer, we have methods to follow the patient afterwards, and we can determine whether there's recurrence, and then we may treat them with another drug or with radiation therapy to kill those cells. So it has nothing to do with the surgery. It's the cancer itself that may spread to other sites before we know it, or may be there and we can't identify it.
Yeah, I think that's why education is so important, because I wonder, that's a myth I heard growing up about that air hits it, and then if you have surgery, the air will help with the spread. And you have to wonder, well, maybe it's because, did people understand their stage? Even when they were going into the surgery, they may have been at a late stage of cancer, and that might account for that, or account for the outcomes even afterwards. Because sometimes even with the best treatment, not everyone survives.
Absolutely.
So you kind of have to wonder about that.
Yes. So all of this depends on the genes that causes these things to spread. People may have we know that there are about 21 genes that were called driver genes that make the cancers grow, and But there are many genes associated with the cancer, associated with the aggressiveness, but they're called passenger genes. And they really don't have a function. So, but the driver genes are the ones. Now, you may only have 2 of those driver genes, or you may have 17 of those driver genes. The more of those driver genes we've found have been associated with a more aggressive cancer. So that's why cancers are different in everyone. And we may treat them differently because they're different.
It depends on the biology of the cancer. It's dependent on these genes. You can have a 1 centimeter or 5 millimeter breast cancer that can spread to bone. But and you can have a 10 centimeter breast cancer, which is considered huge, but it doesn't do anything, doesn't go anywhere. It's just indolent. It's there, but doesn't cause spread. So because it just doesn't have those genes that allow it to spread.
The American Cancer Society has reported that about 16% of all cancers are due to lifestyle factors like physical activity or low physical activity, poor diet or poor nutrition, as well as drinking alcohol. So that means that those about 16% of cancers are preventable to some extent.
Thank you for sharing that. Dr. Assad, there's a myth that says cancer is always painful. Can you address that?
Right, and that's also not true. In fact, we diagnose more breast cancers that patients don't even know about, and they're found with a mammogram. So they're painless, and sometimes they don't even have a lump. And we like to diagnose breast cancer early because the earlier we diagnose it, the more treatable, and the easier the treatment, the higher the cure rates. When the breast cancers or any cancer is large enough and starts to impinge on nerves and cause pain, sometimes that means that it's just too advanced. It becomes a little bit more complicated to treat. Still, of course, treatable. And so most of the time, in fact, breast cancer presents itself as a painless lump, usually in the breast, that can sometimes start to grow. So pain is not the most common presentation.
I think that, the fact that we're, again, I'm just visualizing the fact that this is a cellular disease. You're going into the cells and you're talking about gene expression. And I think people just need to know that these are the things that make our body function, and so good diet and nutrition, sleep, all of those things sort of contribute. But what else can people do, to just sort of dispel some of these myths that are out there and keep them from going to see their doctor?
Yeah, I want to address one issue that you made about the cell, because what we're learning now, the cell is not as important as what we call the microenvironment. There was, in the 1800s, they talked about the seed and the soil, and the seed would be this cancer cell, but the seed needs the soil in order to grow. And what we're now finding, that those things that cause those progression of the cancer cells are actually surrounding the cells. We call it microenvironment. Okay. I'm sorry, I just want to interject that.
No, that was very clear.
Yeah.
That was very clear.
A cancer or a tumor is made of millions of cells.
Oh, sorry.
And each cell can have different genes. So even when we treat it, some cells might die off, other cells might be resistant, so they start to grow. And that's why it's a very complicated process, because the cancer is made of a lot of different cancer cells that might have different mutations. And we call that heterogeneous.
Can I add to that, please? I've been reading and learning a lot these days. What I've read is that these genes cause biological pathways, do multiple things. At the end of the pathway is what are called cancer stem cells. And so it's cancer stem cells that are immortal. They don't die because they continue to mutate. And those are the ones that are resisting drugs. And in order to stop that, you have to go back to where they start and prevent them from beginning. Because once they get to that point, we don't really have a cure for it. Because the cancer, those cells are smarter than we are.
And they want to live.
They want to live.
Yeah.
It's their life cycle. It's like us having kids, They grow up and become adults, but they're different. They look different. And so they resist the drug therapy.
Cancer cells are smart. They learn to turn off the immunity. So normally your immune cells should kill the cancer cells. And normally we have hundreds of cells that may become cancerous, but our immunity, gets rid of it. But cancer cells, when an immune cell comes close to a cancer cell, it can turn it off. And that's why we have immunotherapy. So the role of immunotherapy, or how it works, the mechanism of action, is that it blocks that interaction. And so it turns your immunity back on, so that it should do what it's supposed to, and that's kill the cancer cell. And we've incorporated a lot of immunotherapy and a lot of cancer treatments, and we're studying different immunotherapy combinations for breast cancer and for other cancers as well.
So these kinds of therapies, when people get treatment, sometimes they avoid treatment because they think they can't work. It's going to make them really sick. Can you just talk to us about how things have, is that a myth now?
That absolutely is a myth. I encourage my patients to continue living just as normally as possible and just come to get, their treatments and things like that. But we are so much better at controlling side effects of treatments, especially nausea, diarrhea and other side effects, that patients can go about and do their normal activities and even continue to work. I had a patient who would come and get her chemotherapy, and as soon as she's done, she just goes back to work. And she had no side effects from chemotherapy. It's not like the movies where you see patients who on chemo, lose their hair and then they start throwing up and things like that. We also have, for example, cold caps. If a woman doesn't want to lose her hair, she has that option of wearing a cold cap during the chemotherapy so that she can prevent hair loss. And so we're so much better at controlling the side effects of our treatments that most patients can continue living on and their daily routine just as normal.
I think that's really important to address that, that fear, right? About, am I going to miss work? How's it going to affect my everyday life? That's not only the fear of what's going to happen as a result of the treatment, but just even fear of being diagnosed, right? What is that going to mean for me? And those are the kind of things that keep people from even coming through the door or getting screened even in the first place. And I think that's really important to talk about as well. Dr. Powell, started us off by talking about that, like the fear. And I think also what's important to think about is the mistrust, right? That people are not sure about, what's going to happen or may not have confidence in the treatment or may not have confidence in the providers and the physicians, especially, in diverse communities, including African-American communities, where they may not be dealing with African-American providers.
Thank you so much, Dr.
Thank
Powell,
you.
Dr. Assad,
Yes.
Dr. Thompson. I want to keep on going. We want to keep going, but we are out of time, and we look forward to talking to you more in the future.
Yes.
Thank you so much.
Thank you.
Thank you for having us.
This is good.
Thank you so much for joining us for our show on cancer medical myths. We hope something that was said that would educate you and inform you. We want your voice to be at the table. We'll be sending out a network survey. The information is on the screen so that you can give us your feedback as well. I want you to stay in contact with us. Our website is www.faithcommunityresearch.org. Telephone number is 313-577-5045. On behalf of myself and on our panelists' behalf, as well as Dr. Haley Thompson, Attorney Bertram Marks, who are the co-directors of the Faith Community Research Network, we thank you for your time. God bless you. What an incredible show about our cancer medical myths. But we have a Faith Community Research Network pastor here today that's going to share with us this collaboration that we've had over the past year or so with our network pastors. Dr. Connor is going to introduce our special guest for the Faith Community Research Network Spotlight Pastor.
Thank you, Pastor Chapman. We're so great, godly, glad, and grateful because we've got Pastor Belk here who is doing such phenomenal work, leading and being really a sister soldier spiritually in ministry locally and globally. And so we're so glad to have you here with us today. Thank you.
And thank you guys for having me. I'm glad to be here today.
Absolutely. Tell us about how do you think FCRN, why is it so instrumental, especially in the faith as well as the community and with the research and all the things that are going on with this network? Why is it so instrumental?
Actually, I think it's instrumental because we're bridging the gap. We're bridging the gap with the community and research. When you think about researchers, sometimes you think about in a lab or up under a whole bunch of books. And now we're going to bring that research to the community. And I think educating the community is really important because we have all of the home remedies, we have all of those things that we've been taught. But let's educate the community on how to live longer. And I think that's the goal of the Faith Community Research Network is to live longer.
That's good. That's good.
That's good. A lot of times, as pastors, we focus on in the four walls. Why do you think that it's so important to go outside of the walls, but to also bring in opportunities like the Faith Community Research Network to your church, which you have to also tell us a little bit about what you're doing there and to the community?
Well, my church is Mount Charity Missionary Baptist Church, where our senior pastor is Pastor Frederick Belt. I'm the executive pastor there, and I'm also the executive director of Transformation Life Center. Our outreach ministry is called TOW. We use tow trucks because it means to transform outside the walls of the church. And we think it's important because we consider ourselves boots on the ground. We think it's important for the community to find out about research through the church because the church is still a trusted source in the community. And I think when we bridge the gap with the church and the community, we can get valid research and understanding just due to all of the medical mistrust.
Absolutely. So we know that you've been going through these research modules and training, research 101. How has that impacted you going through? I think we're 3 or 4 segments in. How has that impacted you, and how would you apply some of that stuff back to your ministry?
I think it's the perfect segment with Mythbusters. I think even myself, I've learned with all of the modules and all of the things that we've gone through. And I think it's important now to bring it back to all of the churches so that we can have a deeper understanding, that knowledge and that education so that the community can receive it and that we'll all be in a better place.
What would you say to someone who says, I have faith, so I'm not going to the doctor, or I'm not trusting medical research or anything like that? How would you speak to the balance? I guess is a better way to pose the question, the balance of faith and medicine.
I would say the balance between faith and medicine is that we do have a lot of people in the community that feels that way. I'm just going to trust God, but do we trust the God that's using the doctors? Do we trust the God that gave the knowledge to some of the researchers? Do we trust the God that's giving the information? Or do we trust the person that's standing outside our door in the churches that's knocking on the door, that's bringing the research to you while you're sitting there and while you feel like you're aching and you're not sure what's going on with your body? Sometimes God will bring those resources to your doorstep. So again, it's just bridging the gap and bringing that faith base into it because we are a trusted resources in the community.
And thank you, Pastor Talisha Bilk. And also, of our second show, we talked about the mobile health unit, and Mount Charity, as always, one of our network churches that have already utilized the mobile health unit to service the members of their congregation. We are so glad and happy to have you here, and we look forward to having more conversations with you, Pastor Talisha Bilk. Thank you.
Thank you guys so much.
Thank you.